Good morning. This is a case related to the mitral valve. Let me first start with the clinical presentation. So, this was a 37-year-old male. He had significant MR, the MR being due to myxomatous valve, and he had a single leaflet prolapse, and he underwent mitral repair at another hospital. The surgery was uneventful, and he did well. And the surgical notes stated that he had a A3 prolapse, and they did a caudal transfer, and they also put a ring annuloplasty. He was doing well, but within 2 weeks, he developed a high colored urine, which started to get more and more, and he became concerned. And then he reported to the hospital, and later he came to us, and he was not in failure. Vitals were okay. Echo was done, and it showed a significant MR with eccentric jets. The EF was normal. He had raised pulmonary artery pressures, and he underwent TEE to look at the eccentric jets and where they were coming from. The first image here very clearly shows the ring. It's slightly somewhere in the short axis, slightly off axis, but you do see that thin jet coming medially, and there is another jet coming from the center. So two jets are there, and then you see the ring over there with some reflections happening because of the ring itself. Now you look at the 3D. The 3D here shows the en-face view from the left atrial side, and you have this small jet that is coming at the 5 o'clock position, and that is where the hemolysis is occurring. And then if you look a little closer, I'm not sure whether you can see it on the screen, but there are small tiny jets coming along this posterior arc here. So multiple small sort of wisps, some puffs that are coming over there. So this was a significant MR, two jets, paravalve leak, and that was the one which was causing the hemolysis. And the gradients were not elevated. So at this point, the situation was discussed with the patient. He was definitely not keen on any sort of surgery, and he wanted some sort of other treatment strategies, and he agreed for the paravalve leak closure. So this was at the time of the closure on the table. So you can see the valve a little better here. And what is of interest is that you see it's typical this recent sort of onset placements of these rings. So they are this D-shaped natural ring, and you have the pledgets over there, and you have more pledgets seen anteriorly rather than posteriorly. That is as far as the ring is concerned. And if you look at the leaflet, you see that the A3 is prolapsing over there. So this was the cause for the jet coming through the leaflets. The sizing was done. It was somewhere around 5 to 6, 7 millimeters with a thick width of around 1 to 2 millimeters, slit-like, crescentic shaped. And the septal puncture was done. We went a little high, so because it was a medial leak, which we wanted a little height. And the wire was, the defect was wired relatively easily, so it went through quite quickly. And here you can see the device being put in place. So this was a AVP2 plug, and you can see that after the plug is put in, you don't see the regurgitation happening. So the leak has stopped here. And the last image on the bottom right shows the interventionalist making sure that it is a stable device as he gives a tug, he pulls it and pushes it. So it looked well, and the device was released. And this is the device which is now nicely sitting, and you can see that there is no sort of residual leak coming anywhere around here. And again, use of the X-plane or the biplane, so it gives you also a different perspective from the sides, and you get to see the ring, the device in place, and then as a completion of the imaging, you also look at the gradients. Now, the idea of showing this is that we are seeing more and more of mitral valve repairs, and the complications related to mitral valve repairs are going to increase, and we should have more and more sort of awareness of what these problems are. So this is looking at the mitral valve itself and what is its impact on repair. There are multiple tables, so this is one which I found a little more relatable. So you can see that the ideal ones, and then you have this extreme ones where the repair is not a good one. So it is important to look at the leaflets. If it's a bileaflet involvement, so then it is the success of the repair is not so good. Heavily calcified valves, the mitral ring, if it is heavily calcified, the subvalvular apparatus, significant disease of the subvalve apparatus. And then again, if the leaflets are extensively sort of in terms of not a good quality leaflet, again, the repair doesn't really work. So these are some of the situations where the repair is not a good choice. Now, let's say that the patient is taken for repair. So what are the predictors of MR which can happen after repair? So I'm going to just focus on the primary MR because this was our patient. So typically this is seen more often in the elderly population, and especially related to the anterior leaflet, and then more in the myxomatous valves. And also when you don't have much of the annuloplasty caudal sort of the way it is sort of put in place. So if there's a surgical issue, and then prolonged surgery, and then definitely this experience of the surgical team also does matter, and very high PA pressures, and of course the reduced ejection fraction. So these are predictors of MR after repair. Now, let's look at the problem which happens outside the ring. So predictors of paravalve leak. So what are they? So it can be one cause or it can be multiple causes. So these are, it's a really long list when you look at the mitral valve ring itself. So it can be due to endocarditis, it can be trauma, little unusual, and then of course the LV remodeling can also affect it, again based on how the surgical placement has been made, and age, diabetes, and severe MR also has its impact, and also procedure related issues, how the surgeon uses the suture technique, and device sizing. So if it is undersized, it's a problem. And also where they put the ring. So if it is attached to the basal portion of the AML, and then this will predispose, and this can cause ring dehiscence at the suture area on the PML. And also the rigid rings are more prone. So we are seeing less and less use of the rigid rings and more of the semi-rigid or the natural rings. They are more sort of chosen these days. And then AML prolapse, as I mentioned. And then the other one is that where the ring is put in. So if there is a lot of calcified area, and if the tissue is weak, that also makes it vulnerable. Between the two annulus, so let's see where this is likely to happen. So you have the anterior annulus and the posterior annulus. The anterior annulus is higher collagen density, while the posterior annulus is more muscular. So the leaks or the dehiscence, if the leak is there and if it continues to extend, it becomes dehiscent. So this also is reported quite frequently, usually occur in the posterior annulus, and especially in this P3 segment area. So they have actually looked at this particular area because it's a very vulnerable area. They have made a model also, and they have seen in data, they have shown by data also that this P3 area is the most sort of vulnerable area. So that's because the cyclical forces exerted, especially when the ring is undersized, and also the tissue also matters over there. So if it's a weak, thin tissue, it's again going to be sort of bombarded by these forces, and they sort of give way. And the other one is the dilatation of the posterior annulus, being muscular, so it tends to dilate a little bit, so it makes it more vulnerable, and also this the quality of the tissue there. And the other is a technical issue. So posterior annulus is located deeper in the surgical field, and sometimes the surgeon may not have that much of access. So for some reason, there is a possibility that things may go wrong here. And also, since the circumflex is close by, they're a little more cautious when taking a stitch over there. And also when there is posterior mitral annulus calcification, it makes it all the more difficult in this posterior annulus area. And also the number of sutures. If they put less number of sutures with more distances, then there is this stress between that area is not balanced, and that again can cause the sutures to give way. And also the pledgets. So the pledgets are sort of synthetic supports which are put in between. So if they are sort of not putting adequate number of pledges, if they're not looked into it properly, that again will cause imbalance then. So as far as the treatment of paravalve leaks are concerned, so for this patient, technically it was not there was no challenge as such. It was just that the unusual presentation. So this is a typical sort of flow chart how to address PVL. So when you suspect it, is it causing any hemodynamic issues in terms of hemolytic anemia, which our patient had, or patient is in failure? And then are there any contraindications? No contraindications. Then is the anatomy suitable for the parallel leak closure? And then you go for the closure. And uh, next is, it's just a simple message here. So this is my final slide. So it's all about the parallel leak in a patient with mitral ring. It is unusual, less than 1.5% reported. And it can be broadly classified as being caused by patient itself. That means the nature of the disease, the quality of the tissue over there, and then it can be due to surgeon technical issues, or it can be the ring itself which is going to cause the problem. And what we need to sort of do is, as far as mitral valve repair patients are concerned, especially if those who are at risk or vulnerable patients, we sort of need to follow them a little more closely, at least for the first year, and after that it comes down. And if there are any sort of origins, if there's sighting of any eccentric jets, and if you feel that the parallel leak is there, if the suspicion is high, then it is better to do a T, and then of course 3D can be very helpful. And also we should monitor these leaks, even if they're asymptomatic. If the leaks are identified, especially the posterior leaks, they can get bigger, and this can cause dehiscence. And smaller leaks generally are treatable with device closure, and larger leaks, one has to be cautious because the posterior annulus can be sometimes unstable due to that tissue issues, and one has to sort of review very carefully before going in for a device closure. And if they are really large leaks, they may go for redo surgery. And also with the availability of the valve and ring now, so this is another treatment option that is available to the patient.